What time do you got there?
Got five.
Good time? Well, good. Okay. We're good to go? Okay, everyone, let's go ahead and get started. I think we want to make sure we have given our visiting lecturer, the Cavan lecturer, all the time he deserves to teach us about ECPR and a whole lot of other things. It's really an honor today to celebrate Henry Cavan and introduce this lectureship in his name in a moment. I just want to remind everyone, this is the CME Grand Rounds. I put 47782 on the blackboard for those of you in the audience by Zoom. Make sure you get your CME credit. This is what we have coming up up in the next few weeks. Really wonderful speakers. Pradeep coming from MGH. We have a fellows talk, a faculty meeting, as well as the Larry Cohen lectureship given by Jerry Bloomfeld at the end of the month. So with that, I just want to say a few words. Everyone knows Henry, but I think it's always good to reflect on the impact of someone in an organization and to reflect on what he's done for our field and for us here at Yale. So just to remind folks, he looks much younger than his stated age, which I won't say, but he did graduate from UPenn when I was still in diapers, and then went to Yale for his MD degree, where he graduated in '75. And then he is true Yale and did his residency and cardiology training here, but made a pit stop at the NIH, where I think he made tremendous, had a tremendous impact, a very, I think, career affirming experience, and really, I think, brought that excitement and enthusiasm about academic medicine to our program, and we are all the better for it. I love looking back at people's CVs and looking at what were kind of maybe highlights of what kind of that first spark, and remind everyone, particularly our fellows, that Henry had the opportunity to study with one of the giants of medicine, I would say, and certainly of cardiovascular medicine, which was Bill Roberts at the NIH. At that time, and this was now dating back to 1980, they did a series of seminal pathological studies of transmural MI and aneurysm development. And it's interesting to look back at that time, 45 years ago, on that and recognize that that was the norm. It was common for patients to present, those who survived, with post-MI aneurysms, and to manage that complication. It's also quite interesting to go back and prepare ourselves for this discussion today that Jason's going to lead us through about where the field is now relative to where we were 45 years ago, and the kinds of patients and their complications that we were taking care of then. So a lot of that work really stands on the shoulders of folks like Henry and Bill Roberts and many others who really pioneered our understanding of myocardial infarction and its complications. Henry served many roles for our section, our department, and our school. I'm just going to highlight a few of them that I think have been particularly impactful to my experience here, because I think he really was a great mentor to me when I first arrived, new to Yale completely. He was, I think, one of the original, if not the original, medical director of the Heart and Vascular Center, bringing this conglomeration of specialties together into a unified strategy. And I think that work continues to this day, and I think we still have a lot to learn from how he pulled it all together at that time. He also served the department in many different roles in this section as an interim chief and a clinical chief for many decades, and was towards the end of his career very involved in the development of the Yale Medicine Network, and looking to us to extend ourselves beyond New Haven into where we are now as a kind of comprehensive learning healthcare system across the state. So tremendous work over many decades of really commitment to Yale University, Yale New Haven Hospital. And Henry, I just would like to thank you for all you've done and once again congratulate you for your impact on the organization. Thanks. So with that, I'm going to ask Elliot to come here and introduce our speaker, and we're excited to hear from Jason and what he's going to teach us about resuscitation.
All right, thanks everybody, and condolences to the Notre Dame football team. Go Bucks. I just want to say, it's a true honor to invite Jason to give this lecture for a legend here, giant of cardiovascular medicine, Dr. Cabin. I think he's the perfect person, being a critical care cardiologist and interventionalist. He received his PhD from the University of Iowa in pharmacology, and then completed his MD and internal medicine at Stanford. And then has since been at the University of Minnesota, where he completed cardiology fellowship, an interventional fellowship, and a critical care fellowship. He now leads their section of critical care cardiology. He's the medical director of the CICU and associate medical director of their resuscitation medicine section. And in addition to just being a fantastic speaker, I've heard him speak several times. He's just a great person and helped build the University of Minnesota into, I think, the premier eCPR program in at least the country, if not the world. So Jason, thank you so much for being here.
Thank you so much for that generous introduction. And I would thank you for the honor of inviting me here. And certainly, I think what rings true, I had a chance to meet with many people who are amazing folks today and fellows who are amazing fellows. And I think what I see here is a great tradition of cardiology, but also a great tradition of mentorship. And I see a lot of great, well-mentored fellows that will lead you into the future. And I think it speaks highly of the crew here as faculty as well. So thank you for the opportunity to come and speak with you and discuss the work that we've been doing in Minnesota, and certainly some details of resuscitation and some interdisciplinary work that reaches a little bit beyond cardiology, but also very much within multiple subspecialties. It takes a huge team to make this sort of thing work. And so as we all stand on the shoulders of giants, and certainly that's already been pretty clear, I certainly do as well. And there are many people that have made this possible. So I'll be talking about extracorporeal cardiopulmonary resuscitation for treatment of refractory cardiac arrest, and the role in particular for critical care cardiology, although you'll also very much see the role of interventional cardiology as well. I will talk about all of those things in the huge interdisciplinary effort. We have some funding from R01s related to eCPR trials and specific physiology assessments within eCPR, as well as some philanthropic funding for our eCPR program in the Twin City metro area. So the problem we were confronted with in 2015 is a problem that most communities have, and undoubtedly this one does as well. And it's really important when starting an eCPR program to have a sense of your community data. We were looking at out-of-hospital cardiac arrests across the state of Minnesota, and you can see on the graph on the left is just numerical cardiac arrest figures, and on the right is normalized to 100%. The left, you can see we had about 7,500 cardiac arrests, but about a third of them were shockable rhythms. But what you'll also note is you walk through their hospitalization from the left, all arrests, all the way through ROSC, admission, discharge, and CPC 1 and 2, which you will see recurrently here, which is neurologically favorable survival. What you see is that red line stays relatively flat. If you achieved hospital admission, you had a 66% chance of leaving the hospital neurologically intact, or at least nearly neurologically intact. If you're a PA arrest, there's a big drop getting to ROSC, but then there's still about a 50% chance being able to leave the hospital, a little bit less than that. But if you look at the right side, where we lose the most people is during that ROSC step. So we had a good chance if you achieved hospital admission, but many patients never had the option of receiving care that would be considered critical care or interventional care. They died in the field. And the question at that point in 2014, actually, while we were thinking about this was, how do we help those people? How do we give them ROSC? How do we get them to the point where we can try to save them in the hospitalized setting like we do with the other folks? And that's ECMO. That was the answer we came up with at the time. There were other folks in the world that had been using ECMO for cardiac arrest. We were not the first to do that, but we certainly wanted to refine it and bring it to our community and see what we could do even better than the folks that were doing it at that point. So eCPR is use of ECMO for cardiac arrest. That specialized use. Still though, same circuit, cannulas, an oxygenator, a pump, and a patient. And we use the CardioHelp system that's in the lower right, but you can certainly use other systems. The picture in the upper right is a patient. Head on the left, feet on the right. You can see the red cannula is returning blood back to the patient at the femoral artery. The purple cannula is the blood coming out through the femoral vein. And you have that little sheath pointed rightward, the blue capped sheath there, which is our distal perfusion sheath, perfusing the leg. And there's a little bit of blood that comes off the arterial cannula that perfuses that sheath. So again, this is ECMO circuit. You could use this ECMO circuit for cardiogenic shock, but we wanted to deploy it for cardiac arrest. Thing is, it's only a small part of the system. And this is where the multidisciplinary part comes in. You have everything from the recognition of the cardiac arrest all the way through survivor clinic and getting people back to baseline functional status. And every part of that system is critically important. Every link in the proverbial chain of survival is very important. And we had to strengthen all of them. So we had, as cardiologists, even though we thought at the edge of the hospital walls or the door of the emergency department or the front door of the hospital, we had to go beyond that to the pre-hospital side to work with our EMS crews to help really establish the criteria that we wanted them to screen for, as well as bystander CPR, cardiac arrest recognition, and the communication pathways to get all of this linked together. So our system now is the same as it was back then. We have a patient recognized as a cardiac arrest. 911 is called, EMS arrives, they have a set of criteria. When they think a patient fits those criteria or may be nebulous and unclear, they call our dispatcher. We have a singular dispatcher that talks to our entire team every day. That dispatcher will then discuss this case, link the paramedic on scene to the physician who's on call at that point. They discuss the patient, discuss whether they are in fact a candidate. If they are, the team and the EMS crew meet at a central destination arranged to be closest and sort of bridge the gap between the two parties to get the team to the patient as fast as possible. We cannulate at that site. We'll bring them to the cath lab at that site, and then they go to the ICU back at the University of Minnesota, where we provide the post-arrest care. Importantly, and the part that gets the least discussion, and honestly is going to get a little less discussion than it deserves even today, is the survivor clinic. It's really important. They leave the hospital in still a state of disarray and distress, and clinic is necessary to get them through the rest. And it is an important part that we don't give enough credit, but it is still very much there. The most important criteria or characteristic of this system that leads to good outcomes is time. This is data from the ALPS trial, one of the ROC consortium studies, comparing amiodarone to lidocaine and placebo in standard cardiac arrest, highly trained EMS teams looking at outcomes in pre-hospital, out-of-hospital cardiac arrest. And what they saw when they looked at the time from 911 call to their ROSC, and they compared that to their outcomes, they saw that at the shortest time frame from 0 to 9 minutes, they had about 67% chance of good neurologic status at the hospital discharge. They lost 17% every 10 minutes that went by, and they didn't have anybody with intact neurologic status after 40 minutes of CPR. When we look at our system, this is data from the University of Minnesota eCPR program. We don't have anybody getting to us within 20 minutes because of that whole system that has to come into play. And that's something we'd like to change, but that was a fact at least at 2020 when we published this data. But if they got to us within 30 minutes, we had nearly 100% chance of neurologically intact survival. We did not lose people if they got to us within 30 minutes. However, every 10 minutes thereafter, we lost 25% more people. And this is all neurologically intact survival. So again, 100% neurologically intact survival at 30 minutes, and then dropping very quickly until it levels off around 60 minutes at around 15%. And that tracks all the way to our longest, which was 98 minutes at that time. So we have the option with ECMO, what it seemed like our system provided. And of course, our system is not just ECMO, it's the whole system, including the post-arrest care. But what our system provided was very good survival, longer than standard ACLS, even with highly trained ACLS or EMS agencies, but still a rapid decline with time. And time is absolutely critical. So goals of cannulation, just to touch on these. Again, part of how in our system, the interventional piece is involved. At the very beginning, of our program, all the patients came to the cath lab. Myself and Dimitri Yiannopoulos were the two that were on call 24/7 for the first 2 years straight, cannulating all of these people. And we brought them to the cath lab to do that where we were comfortable. They came to our house basically to be cannulated. We were able to do it fast and safe, 4 to 5 minutes from door to cannulation time. We did it using ultrasound and fluoroscopy, the tools of an interventional cardiologist. Still, even with us, the most common cause of adverse events is vascular complications from cannulation. That's bleeding, could be limb ischemia. The distal perfusion cannula that we now use helped a lot. We evolved in that over time to prevent limb ischemia, but it wasn't clear to us what we should do in that respect initially. The complication or the reasons you might need ultrasound, both the artery and vein are pulsatile, both can be quite blue. So the cheats that we use to know where we are not readily apparent. So ultrasound and fluor are both very important. We use 15 or 17 French arterial cannulas and 25 French venous cannulas. And there's a scale drawing of what that means to a sort of perfect scenario, femoral artery and vein there in the ultrasound in the lower part in a patient just coming in for an angiogram. So this is a person who hasn't gotten 5 milligrams of epi in an hour of CPR yet. And that's what our people coming in for eCPR have. So this is as dilated and beautiful as those arteries and veins can look. And still, if you compare them to the scale drawing of what 17 French and 25 French look like there, they're very similar. You'll also note in the CT scan on the right that venous cannula, which you can see if I have a mouse here. Yeah. So the mouse or the venous cannula will head from the groin all the way up to the chest, to the SVC. So if you follow the two images, these are not exactly in plane, so we had to take two different images, but the image on the top, obviously the chest, that cannula coming from below in the venous system goes all the way to SVC. So we're draining the SVC, the RA, and the IVC simultaneously to achieve good unloading of the heart. We unload the left ventricle with well cannulated VA ECMO. We don't leave a venous cannula in the abdomen. We pull blood from the entire body all at once. And then the arterial cannula, you can see on the bottom figure, or bottom slide there, goes to the distal aorta. This bypasses disease in the iliac, prevents hemolysis. We have a couple different lengths of arterial cannula that we use to accomplish that. So again, with fluoroscopy, we can accomplish this cannulation. If you can't see where that venous cannula is going, it's hard to get it into the SVC safely, at least feel comfortable with that. So the tools of an interventional cardiologist helped with that considerably. You can cannulate in multiple different ways. You can bring the patient to the ECMO. As I was describing, we brought them to the cath lab, as I show in the upper left there. That's actually me and Dimitri during those first 2 years where we're both doing it together. We did every case together. Usually one of us would run the code, the other one would cannulate, and then we'd switch for the next case, just so we could both have the experience of every case we did. The bottom right is now us doing it in the emergency department at one of our mobile sites. That's myself and one of our life linkers, we call them. They're the flight medics and flight nurses that we work with who we specially trained to assist with this procedure. So you only need one physician and one of them cannulating in the emergency departments in our system. You can also bring the ECMO to the patient. In the Netherlands, they do this with a helicopter. In France, they do it on the streets on a tarp. That's shown in the lower left. And then we have this truck. So we've designed a truck, again, interventional cardiologists, we bring the cath lab with us. So we have a C-arm and an ultrasound and everything in the back of that truck that's shown here. So the bottom of that truck is about shoulder high. We use a lift to bring the patient's gurney up into the back of the truck. We put the patient on this fluoro-compatible table. We have the C-arm, the ultrasound, all the stuff in the back. We can bring this to the patient's front door and cannulate them and get them all the same care we would have in the cath lab. We do not do angiography and PCI in the back of that truck, though when we were screening different C-arms, we did look to see that we could in fact do at least angiography. PCI may be challenging in the back of that truck. But to date, we've just done the ECMO cannulation, then brought them to the hospital for the angiography and PCI. This is what our system has currently accomplished in terms of reach. The blue circle is the University of Minnesota, roughly a 30-minute drive time. You're not going to know the geography on this map unless some of you come from Minnesota, so you might remember. But just so you know, the sort of right, maybe fifth, that river coming north-south, if you can see that, that's the Wisconsin border. So we actually reach a little bit into Wisconsin with this as well. They will bring us patients. But the blue circle is the University of Minnesota. The point of this is to show that these other emergency departments that we've added now as mobile cannulation sites serve as an extender. So our first month of doing the mobile program and having patients go to these other 3 sites with the black arrows quadrupled the number of cases we did and extended our reach. It did not, on average, reduce the time to ECMO because they just came from further away. So our average is the same, but those folks who lived in, or had their cardiac arrests at the outer reaches of our blue circle now are on ECMO much faster. So despite the extension and the quadrupling of our patient population, our survival rate stayed essentially exactly the same because we were able to maintain the same services at all these different sites. We've been talking a fair amount of this today, the folks that I've met with. Patient selection is a big part of any eCPR program. Who do you cannulate? Every system, every hospital is going to have a different answer to that. There are strict criteria, lenient criteria. Everybody picks something in the middle based on their ability to balance these different factors. The more lenient you are, the more cases you have, the more survivors you will have. If you cannulate everybody, you will cannulate every single potential survivor. However, there will be a lot of folks that don't survive, and your overall survival rate will decrease as you cannulate more people. Procedural experience, revenue, and resource utilization all also go up the more lenient you are. I have some examples of what lenient and strict criteria are as I talk to different programs, look at different trials, different studies that are published. Usually lenient is around age 75 as the max age, at least as a relative contraindication. We have 75. Strict folks cut it off around 60. Any presenting rhythm would be lenient. We use shockable rhythms, so that we use more strict criteria as the presenting rhythm in that category. Any CPR or no limit on CPR duration would also be lenient criteria. As I will mention, we do not have a limit on CPR time, but we do want mechanical CPR for transport, mostly because we don't want paramedics to injure themselves. There are some additional criteria, which we do use, the physiologic criteria. We require an end-tidal CO2 greater than 10 and a PaO2 greater than or equal to 50 and a lactic acid less than or equal to 18. So they are relatively lenient criteria, but they are still physiologic criteria that people must meet. Signs of life is not something we use, but other programs do, where they need to be gasping, have pupillary light reflexes, or have some GCS that isn't 3 in order to get cannulated. We generally do not use those. This is Dr. Crespo. He was a fellow of ours. He did this project with me. He is now a heart failure physician at Mayo. But while he was with me at the University of Minnesota, he developed this machine learning model that helps predict outcomes that might be amenable to different systems. So if you're a hospital and you say, I can tolerate a survival rate of 50%, then you can choose different boxes. And similarly, if you can tolerate a survival rate of 10%. So for us in this model, if you look at just the rightward part, the leftward part just describes the factors that are most predictive and that we incorporated into the model. So things like the rhythm on arrival, ROSC, whether they had intermittent ROSC, whether they had a duration of CPR that was long or short, lactate levels, and then bystander CPR, the thing, witnessed arrest, other things sort of wash out a bit. But in the model on the right, you can see green boxes, yellow boxes, and red boxes. The green boxes are the boxes that I would say any system should cannulate. These are people with greater than 50% chance of survival. And if you look at the upper right, those are patients that do actually technically have ROSC. They can feel a pulse, but they have a very low MAP, 40s, 50s, despite pressors. These people, when we cannulate them, have nearly an 80% chance of neurologically intact survival, 78%. So I think all those people should get cannulated if you can't stabilize them other ways. If you go down the left, people ongoing CPR, follow that to the left and have CPR less than 45 minutes. Again, this is a population with survival that's greater than 50%. This is a group that I think everybody should be cannulated. But if you go and you have CPR longer than 45 minutes, so again, if you're thinking about cutoffs for a program, 45 minutes is a good one because it differentiates these two groups. If you have CPR longer than 45 minutes, you are yellow or red throughout. So there isn't really a population there that's an absolute, again, in my estimation, absolute must cannulate. But the yellow, we definitely cannulate the yellow folks. So if you have CPR greater than 45 minutes but intermittent ROSC, then you're more likely to get cannulated, especially if your lactic acid is less than 10 on arrival. If you had no intermittent ROSC, but your lactic acid is less than 7, you may also cannulate those folks. Those are all people with more than a 10% chance of survival, but certainly not 50%. And the reds are people that have poor prognostic signs for survival and early survival as a group, less than 10%. So those may be groups that you decline. All of this, again, sort of factors into our system. And those data, that chart was built on patients that we did cannulate and we did have come through our system, but these have been our criteria from the beginning. So we asked paramedics to choose patients between ages 18 to 75 with a shockable presenting rhythm. They can be shocked into PA area systole. but they have to start shockable. If they are still in VF, they have to get at least 3 shocks to demonstrate they're refractory and get a dose of amiodarone to demonstrate that. They have to qualify for Lucas CPR. Lucas is the mechanical CPR device in our community, and that's really, again, for paramedic safety. And we asked them to estimate and only include people with an estimated transfer time less than 30 minutes, but we don't exclude people if it's longer, and our paramedics are very optimistic about drive time. So some people come from very far away. We exclude people who are DNR, DNI, and people coming from nursing homes, not necessarily rehab units. So we have people who are in a rehab post-admission or post-discharge, and we will still absolutely cannulate those folks. But people who are living at a nursing home as a surrogate for sort of chronic disease, we do not cannulate. They come to us if they meet those criteria, or if they're concerned about any of those criteria, they call us and we discuss it, and then we bring them in. And then we have those physiologic criteria with the initial blood gas drawn from the femoral artery as we're getting access. If they do meet criteria, then we cannulate them. We will do the angiogram and PCI as indicated. We may do a pulmonary angiogram if we're concerned about PE as well. And then they get admitted to the ICU. And you'll see there's a little box for organized rhythm. Historically, there was concern that we would just admit everybody to the ICU. And so we negotiated that they had to have an organized rhythm. Could be any organized rhythm, but just some sort of organized rhythm. Could not be VF or asystole when we admitted them. Because of temperature things, as you might imagine, in Minnesota, people tend to get cold during their cardiac arrest. Even in the summers, people are dropping their temperature during cardiac arrest and often come in at 32, 33 degrees after an hour of CPR. It can be hard to achieve an organized rhythm at that temperature, so we give us time to rewarm them a little bit so we can try to get that rhythm, and that happens in the ICU. So generally speaking, now they all get admitted. That protocol is essentially what we used for the arrest trial, which was the first randomized controlled trial of eCPR in the world. We planned for 170 some odd patients and powered for that. We randomized the first 30. These people were randomized in the ED. So paramedics would recognize them in the field. They'd bring them into the ED, tell us that they were coming. They'd be randomized on arrival if they still had ongoing CPR when they arrived in the ED. And they'd go to either eCPR and everything I've been talking about, or standard ACLS in the ED until the ED doc decided it was futile. And that was a very difficult trial for all of us because we had to watch that. We did not get involved in that decision-making. That was standard of care emergency department medicine, but still it was very difficult to watch the futility of that scenario. And you can see that in the rightward graph. Now, after the first 30 patients, we had a preset assessment by the DSMB. And what they found was such profound difference between the two groups, they stopped the trial early. So after only 30 patients, even though we planned for 170, we were stopped early because it was unethical to continue to randomize people to standard ACLS in our community. We had 7% survival in the standard ACLS group compared to 43% survival in the eCPR group. And that 7% was one person. You can imagine at 30 patients, that's one person who we fought to try to get to survive as much as we could. They were trached and pegged when they left the hospital, and they died in the the LTAC after their discharge, which is why the survival after 106 days is 0% in that arm. Despite the eCPR group just continuing to live on. If anything, they get healthier over time as they recover and get stronger, as opposed to that one person in the standard ACLS group. Reminding you that we randomized them in the ED. So this, at the point of randomization, they already had 45 minutes of CPR, which I think in most of your experience is probably low likelihood of survival. We all have those stories with the person who just goes forever and still comes back, but most people do not. So that's a key difference with our study versus others. Prague came along. They were actually doing their study concurrent with ours, but they published theirs after. And they had as their primary outcome neurologically intact survival at 180 days, which they did not meet that criteria, or they did not have a significant p-value and statistical significance at that point. They did have statistical significance with neurologically intact survival at 30 days, but they did not make it out to 180 days. Importantly, this study included all rhythms. I mentioned that we required shockable rhythms as the presenting rhythm. They included all rhythms, and they randomized people in the field on the scene after at least, they required at least 5 minutes of ongoing CPR. So they enrolled a much healthier population, which is why their control group, their standard strategy group, had 29% or 22% survival with no neurologic impairment at 180 days, as compared to our 0, because they enrolled much earlier. Some of those people got ROSC. Not all of their patients required ECMO. The Inception trial came next. This is a trial from the Netherlands, a pragmatic trial. So the Netherlands the Prague study did their whole protocol or set up their protocol much like ours. It was interventional cardiologists in the cath lab, patients brought to that hospital. Inception trial was entirely different. 10 centers across the Netherlands. They all had ECMO programs, but they didn't necessarily have eCPR programs. So for many of those centers, their very first eCPR patient was in the trial. They had cardiac surgeons, interventional cardiologists, critical care docs, ED docs, all cannulating at different, depending on the center. They did in various places. And they didn't have any protocol for post-arrest care that required anything about how long they'd wait for prognostication or anything like that. And you can see they did not even come close to meeting the primary outcome. They had very few survivors in the ECMO group compared to the standard group. They are basically flat across the groups. So when it comes to thinking about the ICU, and actually eCPR in general, these are the things I just point out to you. One is that, again, eCPR is the system. The Inception trial in particular did a great job with the system pre-hospital. They got patients to their hospital in 36 minutes on average. They were moving, they did a great job, but they had 74 minutes time to ECMO. So they're cannulators that weren't used to cannulating in the setting of eCPR from a variety of backgrounds in a variety of places were taking a while to get on pump. And that delay, as I showed you in the data from our program, the time is really, really important. So 74 minutes is a long time. Their median ICU length of stay was 1 day. It is very hard to know what the outcome of a cardiac arrest patient is going to be in 1 day unless they're all catastrophically neurologically devastated, which 74 minutes, maybe many were. I can't say that. They didn't publish that. However, 1 day is too short for most ICU care and neuroprognostication. So as much as, again, it's a pragmatic study, it gives us a sense of what it would be like if we rolled out eCPR across the United States today in a bunch of hospitals that don't currently do it. It is not a sign of what eCPR can do, in my estimation. This is a demonstration of when their different centers came online for the Inception trial. You can see COVID undoubtedly made an impact as well, but certainly there were some that came on later. But if you look at 56 patients attempted cannulation in 10 centers over nearly 4 years. So you think about it, many centers are doing 2 cases a year. That's something they've never done before, and putting them in a randomized controlled trial. So again, pragmatic, absolutely, not a demonstration of the technique and what it can accomplish. So a bit of a case just to talk about now, transition to the ICU portion of this. So 56-year-old male, no relevant medical history, presenting by EMS with refractory cardiac arrest to work. He complained of chest pain, fell to the ground. His coworkers provided CPR. They had an AED on site. They hooked up the AED and gave him 2 shocks without resolution of the rhythm. EMS arrived 4 minutes later after those 2 shocks, and they gave 5 more shocks, 4 milligrams of epi and 450 milligrams of amiodarone while they were transporting to us. They were optimistic about drive time and got to us 82 minutes after the 911 call. We used our standard cannulas, cannulated the standard way. You can see the angiogram. So again, we're cannulating in the cath lab for this gentleman because he came to us. We're cannulating, we do this angiogram. You can see the proximal LAD is flush occluded with a thrombotic occlusion. We were able to open that up, restore flow. The picture on the right, of course, just demonstrating this very large LAD territory, which undoubtedly was the reason that he arrested. You know, nice, robust LAD. Not much disease in other places, but the acute occlusion is certainly a problem. So now cannulated an ECMO, underlying etiology addressed. We bring them to the ICU. So post-cardiac arrest care is generally thought of as a mix of these 4 things. You have brain injury, you have myocardial injury, you have this profound systemic inflammatory response and vasodilation, and you have the persistent precipitating pathology, which we have dealt with here, the coronary disease. Could be PE, could be other things as well. The problem when you have 82 minutes of CPR is that everything else is also affected. You have renal disease, kidney disease, or renal disease, lung disease, you have trauma, a lot of trauma in these patients, and really 24/7 multidisciplinary care and very high level intensive care is really important for this patient population. We do have a very high predominance of coronary disease. And so again, in most of these people, we can fix the underlying pathology. In some people, it is, as you can see here, we have, in the first trial, we published 84% had severe coronary disease, about a mix between 1, 2, and 3 vessel disease. We don't fix all 84% because some of them have that 70, 80% lesion. We're fixing critical stenoses generally or thrombotic occlusions, but we do fix some that are not a TIMI 0 situation. But we also fix some very severe and complex disease because these patients are not immediately eligible for a CABG. There are some patients where we'll say we actually have decent flow down all these vessels, even though there is 3-vessel disease. We will admit them to the ICU with the plan that we wait for neurologic recovery and then we call surgery, and they will do CABGs off of ECMO as long as we can demonstrate some neurologic recovery for those patients. But otherwise, we're doing some complex PCI in these patients with the stability provided by ECMO, which is actually a very nice way to do PCI. Sometimes the heart's not even moving because it's in VF still. And in some patients, they won't convert from VF until you fix the coronary lesion. We shock and shock and shock, even on ECMO. We fix the lesion, shock once, they're out. And so that precipitating pathology is really important. And so sometimes it's a very surreal experience doing PCI on a heart that's not beating. Or at least not in a synchronized, organized fashion. So you can see our ECMO flows here. So this data and the data in the next couple slides will be separated into 3 groups and color-coded. So green represents patients who go on to develop brain death, presumably the most severely injured patients. Blue patients are patients who go on to survive neurologically intact, and red is for patients who die of some other cause that isn't brain death. They can still have a neurologic injury-related death, but just not brain death in the strict criteria fashion. So the flows, 3.5 liters, higher flows in those who develop brain death because they tend to be the most vasoplegic, so we have more flow in those patients. Still, despite that flow, lots of vasoactive medicines, including vasopressors in the vast majority, but we also have some vasodilators used. Importantly, we do control the MAP with a high and a low limit, so we do give vasodilators in some patients. The lactic acids are high in everybody, and usually 12 or 13 on average, and they come down quickly for those who survive, slower for those who don't. And we give a fair amount of blood transfusion to get them through their overall event. You can see the LVF on day 0 is quite low, or day 1. And in those who have enough time to demonstrate it, generally will come up to normal or near normal. There are a few people who still recover after discharge, but generally speaking, most people's hearts will come back. Again, a lot of predominance of coronary disease and acute lesions, so they recover that function. There are a few patients that have gone on to LVADs and transplants in this situation, though, so that's certainly something that our teams over the years have been working through how to tease apart which ones will be eligible for what. You can see troponins can get very high. This is before high sensitivity troponins, published in 2018. Everybody has some amount of acute kidney injury, but it varies based on severity of injury, liver injury, glucoses and insulin requirements all over the place. Trauma is really, really important, and it points to the importance of the team. So you can be the best cardiology ICU doctor, as we hope that my whole team is, but you can't fix this. This is a quarter-size hole in the right ventricle. So this is a patient we cannulated, was very stable at first, was chugging, meaning they didn't have enough preload for the circuit, and the circuit kind of jumps. We sent them up to the ICU with a lot of fluid repletion, and over time went to the point where the circuit could no longer function at all. It had no preload, and when we looked with an echo, very large pericardial effusion, tapped it, pure blood, bedside. So we called the surgeons, kept on pulling blood out so that we could get some flow of the ECMO circuit. But the surgeon asked one question, which was, does he have a chance to survive? This is a day 1, hours out from his hour of CPR. We didn't know how he would do, but we said that he has as good a chance as the rest of the group. They said, fine, we'll take him to the OR. They found this hole in the right ventricle, patched it. The gentleman was he played the organ at his church. 2 weeks later, he was playing the piano in the hospital lobby. And now he went back a couple weeks later and was playing the organ in his church again. He still sees me in clinic, still playing the organ. Complete recovery. But if we didn't have a team, then it wouldn't have been possible. He would have died because I can't fix a quarter-size hole in his right ventricle. So we needed everybody to be on board with this process in order to make this work. Other types of trauma, that's obviously one of the more dramatic types of trauma. Other injuries, rib fractures, lung injuries, some liver lax and splenic lax from the CPR. All those things are possible injuries that need to be addressed by different teams and different people in different ways. So it just, again, points to the 24/7 multidisciplinary care. Acute lung injury. This is Dr. Alejandra Gutierrez. She's one of our other CICU physicians in the team here at the University of Minnesota. And she did this work published back in 2023 looking at the acute lung injury. Now this, we can't really differentiate between pulmonary edema, bleeding, contusion, ARDS, pneumonias. All those things are sort of lumped in together. But when she looked at CT scans from these patients, a very high predominance of injury noted on CT, predominantly in the posterior segments of the lungs, not surprising. That's where a lot of those pathologies will land. The more surprising thing was just how severe it is, which is that the compliance of the lungs on average are pretty much right on the line for ARDS. So when we're treating these patients in the ICU, we're not just treating a post-arrest patient, a cardiac arrest patient with a coronary history and coronary issues. We're treating an ARDS patient functionally as well. And this is where that expertise of the ICU team is really important. That said, despite the fact that we treat all those things, recovery is still a marathon. So this is data from the first 555 patients that we had. As I mentioned, those physiologic criteria, the blood gas, we do screen out about 20% of our patients because they fail those criteria upon arrival. So about 80% of the people get the full treatment as I've been describing it. We had about 75% of the people admitted to the CICU after all of that. And so of that 75%, 40% left neurologically intact with CPC 1 to 2. A very small percentage leave with a substandard neurologic state, but not dead. And then we have brain death in 23% of the overall population and other death in 34%. You can see in the upper right, you can see in the upper right that the length of stay is much longer for the people who survive, which makes sense. So you have a population that tends to die early. But you have still 5 days on ECMO, about 2 weeks in the ICU, and about 3 weeks in the hospital for those who survive neurologically intact. It is quite a marathon. And then if you look at the graphs, that line graph with the multiple colors is the graph for only those who survive neurologically intact. This is their sort of timeline of recovery through their hospital stay. About half of them following commands at around a week, 5 days to 7 days. And then they are extubated shortly thereafter, and they go through their hospital stay. Those who die, again, on the bottom graph, just the deaths tend to die early, with half of them dying within the first 3 days. And that's dying from catastrophic neurologic injury. So if you look at those who die, these are the percentages. This is the percentage of deaths. So 40% of those who die of brain death. 31% of those who die of an anoxic brain injury. So by far, it's the brain that's the limiting factor. There's a smattering of other things. It also points to each of those people who dies of a neurologic injury has a chance to be an organ donor. And we have, and I can talk more at the end if you'd like, about the increase in our organ procurement from this population. Certainly not the outcome we're hoping for. We're pushing for survival, of course, but they can still provide a benefit to society even if they are not a survivor. This is my favorite, the intensivist in me at least, this is my favorite slide. This is when I walk into that patient's room every day of their hospitalization, what is their chance of walking out of the hospital neurologically intact if they have not yet followed commands, nor have they been declared dead? So on day 0, it's 40%, because that's roughly the number of people who have neurologically intact survival. If they survive the first few days, it actually goes up. And then, because a lot of people are dying during that time, but then it starts to trickle down. But the important point to note is even out to 30 days or 29 days, it's still around 20% chance of neurologically intact survival. So if that patient in the ICU is not following commands, they still have a 1 in 5 chance of walking out of the hospital neurologically intact after a month. And that's an important perspective when you're trying to talk to families and staff about what we're doing with these patients. That said, resource utilization is key. If you're waiting a month for all these patients, it's really hard to have all those beds taken up with all these patients, especially when you do 300 of these a year. And so we've been working to understand early prognostic markers that we can use. And this, again, AHA guidelines, 72 hours after cardiac arrest. I don't want to give you any misunderstanding of that. That is still the AHA guideline. That said, this is a specific population that actually is not in most of the studies that inform the AHA guidelines. And this is a slightly different mindset of what we're going to use it for. But still, neuroprognostication becomes very important. If we can do it earlier, we can help families and stop torturing them with not knowing how people are going to do. And we can decrease the huge resource utilization issues that come with a month of waiting for comatose patients. Some important notes, if you're involved in neuroprognostication along the way, for this population at least, that people get very concerned about posturing. We're all taught about posturing in med school. Does not relate to outcomes in this population. In fact, I usually argue, it probably matters the trajectory. If you're normal and you start to posture, that's bad. But if you're dead and then you start to posture, it's a sign of recovery. And that's what we sort of see. Like these people, it's part of the brain coming back online. Tremors and myoclonus, that's not prognostic. That's actually true also for cardiac arrest patients in general, that myoclonus does not help with prognosis. roving gaze is concerning to many practitioners and does not provide any help with prognosis. And inappropriate tachypnea, it seems like it's part of the brainstem waking up, that they will start to overbreathe the vent. Their blood gases will be way abnormal because of overbreathing. And it seems like it's part of their brain waking up. So it's another part we just have to work through because it tends to trigger extra sedation and delay prognostication and recovery in other ways. These are other factors. These line graphs are other factors that relate to recovery in the clinical exam. First of all, the neuromuscular blockade, the paralytic use, can definitely impact your ability to prognosticate. We try to get that off as quickly as possible. And the sedation also definitely impacts that. And you can see as we're trying to wean that off over time over those first 5 days. Importantly, though, if you're just using GCS and neurologic status, GCS on day 0, over half of our survivors, people who will go on to survive, have a GCS of 3 on day 0. So as we think about criteria, you're thinking about prognosis, just keep in mind that this GCS of 3 lasts a while. And even over 10% of our survivors will have a GCS of 3 on day 2. So it hangs on for a long time. And absent brainstem reflexes, 10% of our people have 0 brainstem reflexes. 10% of our survivors have no brainstem reflexes on day 0, but they all get them back by day 1. So when using brainstem reflexes to prognosticate, keep that in mind. Okay, many other neuroprognostic factors. I know this is a very busy slide. It's just to point out that there are a lot of ways that we can assess neurologic function. And many of them have sensitivities and specificities that we can measure in 555 patients. In terms of neuroprognostication, we want something very specific for death, meaning if we say they're going to die, they're going to die. And we want something that is as sensitive as it can be, but we'll sacrifice that. So a 50% sensitivity, if we can screen out 50% of the people who are going to die, that's still useful, even if it's not 100% for sensitivity, but the specificity needs to be high. So we look at brainstem reflexes, bilateral NPIs, these are pupillary reflexes that are sort of objective measures of pupillary reflexes, GCS of 3 at 24 hours, cerebral edema on the admission head CT, anoxic injury on that head CT, non-convulsive status epilepticus, status myoclonus, or isoelectric EEG on EEG monitoring, and neuron-specific enolase or S100B, which are sort of brain troponins. So we look at all those things and we say what's sensitive, what's specific, and we can make a chart like this to say those things that are highly specific, high on the graph, are the ones we want to use, and we'll sacrifice the x-axis, which is the sensitivity, but ideally the perfect thing would be in the upper right corner. But when we look at those things that are most sensitive, most specific and not as sensitive, this is the kind of approach we can develop. And the reason I belabor this point is just to say that we are making progress in this resource utilization point. So as you're thinking about how a program would be put together to do this in a broad way, these are the kind of data that are helpful. And this is the approach that we'll be using to try to help us with this issue. So if you have any of cerebral edema on an admission head CT, non-convulsive status within 24 hours, isoelectric EEG at the 24-hour mark, or those neuropupillary reflexes less than 2 at 24 hours, then you, at that point, already have a 100% chance of death. And we can talk about the issues of neuroprognostication, but we've avoided many of those in this population by waiting a long time. Our protocol from the beginning was wait for a week before we neuroprognosticate at all. So this has gotten rid of at least our bias in that part of the process. But again, if you have one of those 4 findings, 100% chance of dying, whether it be brain death or another death, it's still death. Tier 2 is a combination of multiple factors where we get to a 99% chance of dying. And together, our total predicted of those who have poor outcomes is 70. If we use tier 1 and tier 2, is 75%. We can predict 75% of the deaths this way. With just tier 1, if you wanted to be a stickler and just have the 100% death likelihood, 69% of the deaths are predicted by those 4 characteristics. So we are able to make some headway on that front. Importantly, this gives you a sense of which patients we are able to predict. Not surprisingly, those with brain death are predicted at a higher rate by these than other forms of death. If you die of a perforated bowel, that's harder to predict with neurologic markers. But still, there is some correlation. We still do pick up some of those patients who die from other causes as well. And with that, an assessment of how many hospital days we save, which again, for resource utilization is important, and also for families. When we're waiting a week to neuroprognosticate, we're also telling the family we can't possibly know. They may live, they may die, it's hard to say. And that's a very hard spot for families to be. Of course, they want their family member to survive and they want to know it, They will accept, though sadly, death and knowing it. But the gray zone of not knowing alive or dead is like torture for them. But it is what we've had to do to keep them going so we can help our patients survive if at all possible. This is the effect on those two curves. If we use those two tiers of neuroprognostication, you can see the big jump in deaths in the first day because we're making this assessment at 24 hours, but still there are a few people who die later. And in terms of that, again, the favorite graph for me walking into that room, now on day 2, I could walk into a patient's room and say, you have not been declared dead. You have not followed commands. You have a 75% chance of neurologically intact survival. It still dwindles over the course of time. But there again, even out to a month, now you're closer to 30 to 40% chance of neurologically intact survival. So our patient, 82 minutes of CPR, he was stabilized well, did well, but did too well. He developed this lung injury. You can see the CT scan on day 1, or on admission, and then on day 8. And you can see there's all sorts of stuff that was probably there to begin with, but we just couldn't fully appreciate it because that big consolidation in the upper right, the aspiration event that occluded that upper right bronchus, which we went on to bronch and pull stuff out from, that opened up. But now the stuff on the left got worse. As the heart recovered, the heart started to pump more blood through the lungs, and now we had hypoxic blood that was not well oxygenated by those lungs going out in the aorta. And that's an entity called north-south syndrome, which we see relatively frequently because of the lung injury in these patients. And so by day 8, there's very limited function from the heart initially on admission. And then on day 8, we have a more robust heart that's moving that blood through the lungs. And we have this entity, again, north-south syndrome. It doesn't take much flow. This is computer modeling using CT aorta of one of our patients to sort of get a sense of how much flow you would need to achieve hypoxic blood getting to the brachiocephalic artery and therefore to the right side of the head, which is what we worry most about. And it's only about a ½ liter. Now, whether or not that's correct for everybody's aorta and everybody's heart is hard to say, but it doesn't take much less than we would have predicted. And so really it points to this issue of north-south syndrome in many of our patients with bad lungs. There are many ways to treat this: improved vent support, bronchoscopy, and things you can do to optimize the lungs. And then in the end, we get down to more advanced cannulations, VA-V ECMO and central VA ECMO cannulation, which is shown here. VA-V ECMO is essentially another arterial cannula, but it's in the vein this time. So it's a return cannula that takes some of that arterialized blood back to the jugular vein to create a VV ECMO circuit now in addition to your VA ECMO circuit. Or you can do central ECMO, crack their chest, put cannulas directly in. We chose VA-V ECMO. So on day 10, we cannulated for VA-V ECMO, kept the VA ECMO in place that we had, added that one cannula and wired it in so we were able to get that flow. Day 12, we removed the arterial cannula that we had before in the groin. And so now we were just on VV ECMO, still needed a trach, decannulated VV ECMO on day 22, awakened following commands on day 26, and discharged from the hospital on day 34. So this gentleman, long time in the hospital, 3-month follow-up, back to work. Back with his colleagues who tried to save his life with bystander CPR and using that AED. The bystander CPR undoubtedly helped him. The AED didn't do a whole lot other than demonstrate that he was refractory. But the CPR was critical. So they did functionally save his life, and now he's back working with them. I still see him in clinic every 6 months to a year as well. In this clinic, so our CICU survivor clinic, and I just want to give one shout out to the idea that, again, when people leave the hospital, they're not fully recovered. They don't remember much of their hospitalization at all. We have to run through every aspect of their hospitalization and what we do and what we did so that those words they hear from their family make sense. We stop some remaining meds that may be on board, the antipsychotics that they had for their delirium somehow hang on for a long time, so we stop those in the clinic. We make sure they're in rehab, getting their cardiac rehab as well as all the other rehabs. We discuss other survivor resources. We have a Minnesota Sudden Cardiac Arrest Network in Minnesota, so a support group run by survivors, and we get them enrolled in that. We give them referrals for them and their family to psychotherapy and neuropsych testing as well to see if there are any additional deficits we need to work on. We talk to them in detail and to their chagrin about driving restrictions and about barriers to physical activity and sort of how to free them from those barriers. The most common barrier is their loved ones asking them not to move because they're afraid they're going to have an arrest again. And so we try to give them all the comfort that things have been fixed, their insurance policies in place, ICD if they got an ICD, and then we fix their coronary disease when we fixed it, and that they are unlikely to have another event, but they need to get out and exercise and mow their lawns again. So we run through all of that. One last thing is just to note that in 2023, there's a focused update from the AHA that brought eCPR up to a 2A recommendation based on the studies that were available at the time, the ARREST trial and the PROG study. The INCEPTION trial was not out at that point. I am involved in guideline writing with the AHA for ACLS, but not in this chapter of those guidelines. So I don't know what they're going to do with this guideline coming up in 2025, but they're currently discussing it and working through that process. So more to come on that. But we certainly were very specific in 2023 about the highly trained and centers with select patients. And I think it comes down to the limitations of the process, which patients to select and where and how to do it, what system to work in. So in summary, eCPR is a system of care. Every aspect of the chain of survival is very, very important, including parts near and dear to my heart in the cath lab and the ICU, but certainly all other parts are also important. Patient selection criteria are very important and really depend on what the system that we're talking about can rely on and can tolerate in terms of risk. Rapid and safe cannulation is critical, using the tools at hand. And again, I'm biased, but I do like having fluoro and ultrasound to get a 100% cannulation rate in the safest way I can possibly do. Multi-system organ failure, and I call it pan-system organ failure, is ubiquitous. It's everywhere. These patients need high-quality 24/7 multidisciplinary care, which I think is very well provided by a cardiology ICU team with trained people thinking about the heart, but also thinking about everything else and able to deal with everything else that these patients bring with them. Recovery is long but durable, and people can absolutely return to normal life and have come back to our clinic for years and years telling us about all the new vacations, grandkids, all the things they're doing. And of course, as I mentioned, critical care cardiology is well suited for this. I hope at some point we'll have a new link in the chain of survival with an ECMO circuit in it. This is a group of our patients and why we do the work. This is a subset of our survivors who came to a survivor dinner that we had 2 years ago. We try to have these every couple of years. Going to have another one next October. But these are people, you just sit in a room and suddenly everybody around you is a cardiac arrest survivor you never would have known after talking to them. So it's really amazing, but it takes a huge team to accomplish this throughout the hospital and before and after. And it's really nice and wonderful. And I really appreciate the opportunity to present this on their behalf to all of you to discuss this, and happy to take any questions that you may have. Thank you.
Maybe I'll get started, Jason.
Oh, please.
Fantastic talk, and I think just give us a perspective on what can be accomplished with the team and focus. You spent a fair bit of time appropriately teaching us about neurological recovery. You mentioned it briefly, but I'd love to hear more from your own experience, what you find in regards to myocardial recovery in terms of LV function and kind of heart failure status post recovery.
Yeah, so a great question. And so 90% of these patients that survive and recover will recover full heart function, be back to normal. They'll be treated like a STEMI patient. I mean, really functionally, they come back to clinic and we see them and we talk about chest pain symptoms and things and try to just help them through the medication regimen that comes with being a STEMI patient, even though they obviously had much more than a STEMI. But 10% do still have some leg in that cardiac recovery. And so you can think of it a little bit as in general, the brain is the weak link. And if your brain survives, your heart generally does okay. But in this 10%, that's not true. And some of them may have had some pre-existing disease. Most of the patients that we see do not have a known cardiac history. Their first symptom of cardiac disease was this cardiac arrest. And so it's not that they've been sitting on an EF of 10%. We do have a few people like that too, that were being worked up for a transplant or thinking about a VAD or, whatever reason they had a low EF and hadn't gotten more definitive care. But the vast majority are not that way. And so what we do see though, in this 10%, for whatever reason, they have a low EF after, they have poor functional status after. We do bring them into our heart failure community and they are evaluated for LVADs and transplants. And we've had those outcomes as well. And they do very, very well. Generally speaking, they are able to bridge out, get out of the hospital, get discharged and do rehab despite the diminished cardiac function and come back or continue that outpatient evaluation and then come back for those treatments. But we have had a few that have stayed in hospital, had the neurologic recovery required so that people would feel comfortable that they are going to wake up and they will be able to take care of their LVAD batteries and They'll be able to take their meds for the transplant, and we've worked in that direction. Nowadays, in the modern era, and this is like, since 2015, we've been doing this, but in the last 2 or 3 years, they will generally bridge, if possible, to an Impella 5.5 and be walking around the unit. So they transition to something that's an ambulatory support mechanism, so then they can bridge to an LVAD or a transplant and be in tip-top shape. But the folks who have biventricular failure, it's less, they're less able to accomplish that, in which case we've had a couple transplants, not many, but a couple transplants off of ECMO, and we've had a couple LVADs off ECMO too. But we do everything we can to get them to a point where they can rehab first if we can. Yes, sir.
So it's incredible results. I mean, it's an amazing project.
Thanks.
Incredible results, and I congratulate you. I sit here though, and I wonder how in the world that can be rolled out to other places like here. I mean, I think about the amount of resources you're talking about, beds, ICU, skilled intensivists, and then in the cath lab, if you have 10, 15, 20 people on call, sharing call at different hospitals, how those people are going to get the skill set that you dedicated yourself being on every night, I guess, with your partner for a couple of years, or that it's staggering. Is it realistic for a place like ours, which is a huge medical center, and yet to commit? I look at Francine and I think about the financial commitment that this would require. Can you just comment on that?
Yeah, it's a great question. I mean, I think there are analogies out there. I would argue that this is not dissimilar. I mean, there are unique aspects to it, but it's still in the same category of wanting to start up a transplant program or wanting to start up an aortic dissection surgical program. And there are different parts of both of those that are similar to this, and they don't overlap perfectly. But I think yes, it's resource intensive, it's expertise intensive. I don't think that the nation should just think that tomorrow we're going to start ECPR in every hospital. I think that would be a disaster. I think that with training, and we have trained other people now, those first 2 years, 2015 through 2017 was a time when we were doing that. But now all of our interventionalists do this as part of their STEMI call. When we're on call for STEMI, if there's an arrest coming from the outside, we'll go in and cannulate that person. If there's an in-hospital arrest, we'll go in and cannulate that person. We have, for the mobile part and those the black arrows that were the extra hospitals around, we've trained a couple ED critical care docs. So not to say that it can't be non-interventionalists, but it takes a lot of training. Each of them dedicated a year or more to that training process, not as their sole job. They still had full work in their emergency departments and ICUs, but they dedicated multiple shifts a month, upwards of 5 a month, for them to be on 24 hours that day, 5 times, to do any cases with us and have sort of a mini fellowship in it. I think we can train people like that, and we can get them teed up to do it. There are the reason I like it, well, I'm biased also as I'm an interventional cardiologist. The reason I like interventional cardiology for this, though, is when you're not cannulating for ECMO, you are still using very many of the same skills. And I think that's where that overlap makes a lot of sense, along with the fact that we have STEMI protocols and pathways to get patients into the hospital already quickly, and teams. It's also skill set. And those ED critical care docs, one of the things they had to work on was having a critical mass of cases where they could actually get the expertise to maintain it. And that's been the challenge for them. But I think we can definitely roll this out to different centers, but it does require dedication and resources, absolutely, without a doubt. But I think in terms of resources, if you're just thinking about dollars, generally speaking, these patients do provide reimbursement that is helpful to sustain the program, let's say. And it's going to depend on different areas and payer base and all those things. But that part tends to work itself out. It's the human capital and that dedication and time from people. And that's hard, it is, but I think it's doable. So I'm happy to work with any program. And I can also understand if people say that's great, but we're not ready for that, or we don't want to do that, or, I understand all those things, but I think, a very energetic group of people who have the willingness to be dedicated can make this work, and the financial stuff tends to work itself out eventually. But great question though, absolutely.
Yes, John, go ahead.
Thank you. Thanks for a terrific seminar.
Thank you.
Cell metabolism slows down in the cold, and tissue preservation is improved. So I wonder with your patient whether he arrested during the Minnesota winter or during the summer. Is there any difference in prognosis and outcomes, particularly from the brain perspective?
Yeah, so great question. Could we take advantage of our natural environment to actually help some people, right? We have to deal with it. Why not benefit? It seems not. I mean, it seems like our survival rates are pretty consistent across the year. We've looked at the sort of yearly differences, day of the week, time of day, all those things, and everything's pretty flat with some noise, but not anything consistent at least. We do have the surge generally in number of cases when the first big snowfall happens, which honestly this year hasn't happened yet. So we're still waiting for that shoe to drop, or that foot to drop. But it's, when people start shoveling and they have their stress test at home that they fail and then they have their cardiac arrest, we do see that trend absolutely in Minnesota, but it doesn't necessarily relate to a higher survival rate. The tissue preservation is an interesting point. Most of these people arrive to us cold already. Even in summer, they arrive to us like 32 to 34 degrees. And so it's, that passive cooling may be important. When you look at things like the TTM trials, there was a delay in when they achieved their goal temperature. And for us, they're at goal temperature when they arrive, before they get reperfused, because they're being reperfused with the ECMO. So presumably, they may actually have more benefit and a better outcome than the TTM trials would suggest from therapeutic hypothermia. We don't know that. We need a larger sample of patients to be able to do a real trial in TTM. There are so many, all the questions and complexities of post-cardiac arrest care are reproduced in this population without any data at this point. We still do need good trials to look at it. And I think it raises a lot of interesting questions about how we can maximize that tissue benefit or tissue preservation, as you say. Yeah, it's a great question, though. Minnesota's cold, but it's not cold enough, I guess. Yeah.
Last question.
Jesse, thanks a lot. I learned a lot. And actually, just as we discussed, I'm doing the basic research for the cardiac arrest. And just as you know, in the rodents, we couldn't do ECMO. So my question for you is, since the cardiac arrest, that's a systemic ischemic reperfusion, multiple organs, especially like brain and heart, get damaged, contribute to the death and the neurological dysfunction. And my question for you is there any drug or candidate drug which can protect this kind of brain and heart at the same time, which can, we can pursue for the, preclinical study?
That's a great question. As you know full well, there are many drugs that have been tested in animals that have not panned out. There are many things that were hopeful, and for whatever reason, they haven't worked in clinical trials for cardiac arrest in general. ECPR has these unique aspects, which may make them more amenable to some of those treatments. And again, you could go back and dedicate an entire career to reproducing all the clinical trials that have been done in cardiac arrest in general, just in this population, and would maybe find some new candidates that actually would work. The thing I will point out in addition is that when you think about what a drug has to do for a patient that doesn't have ECMO, it cannot negatively impact heart function, or it will cause rearrest or preserve or continue the arrest, right? You have to worry about heart function in response. When you're on ECMO, you only worry about the brain. So if you think about like a phenobarb load to protect the brain, this was something that was neutral in the trial, not helpful, but that has hemodynamic consequences and cardiac consequences. If you can get rid of that concern, now maybe you can focus on the brain and maybe you can see some benefits from these drugs. So it is true that there are things that we've already tested that may be beneficial in this group that we don't know yet. That said, thinking about ischemia reperfusion injury, there are a few drugs that have been sort of bandied about, and we talked about ketamine this afternoon has been a consideration. Glyburide has been a consideration with glutamate transport. There are some amphipathic molecules that may seal blood-brain barriers and prevent leak. We see a lot of third spacing and sort of capillary leak in this population from the inflammatory response, we think. Steroids have been tried in non-ECPR patients and not been all that beneficial. Maybe they would be in this population. So there are a lot of things you could imagine that you might try that would be helpful for this population. But the issue for us on the human level we'll be having enough patients to be able to do these clinical trials. And we were talking earlier, the key thing here is multi-center clinical trials, having patients from good centers that are not doing their first ECPR patient and putting them in your trial, but are established programs that have good results, baseline results, and can we make them even better on a multi-center level? And I think that's what I would love to be able to do as more centers come online. That's what we need to do. How we do it, I think the details are going to matter a lot in how we set that up. But I think it's a fertile ground for lots of study. And with that mechanistic understanding that can go back to the basic science side, I think we inform each other, and that's the joy of this stuff. Yeah.
Well, let's welcome Jason to Yale and thank him for giving a great Cavan lecture. And thanks for being here with us.
Thank you. Thank you, Dr. Cabin, for being such an example for everybody. So I could be giving this lecture today, so thank you.
When I started, Clement started, we're offline. Started our residency in the CCU at morphine, a couple of times. Maybe in